This presentation is designed to provide information on managing key symptoms in patients who are unwell with COVID-19. My name is Dr. Kate Shorttoes and I'm a consultant in palliative medicine at St Margaret's Hospice. What symptoms might patients commonly experience? Experience to date suggests that patients with COVID-19 commonly experience symptoms of breathlessness, which can be severe, cough, high fever, and delirium and agitation, particularly towards the end of their life. So first, thinking about breathlessness. This can be defined as a subjective sensation of discomfort with breathing. Breathlessness can cause significant distress, especially when associated with anxiety. It is important to consider whether there are other reversible causes. Some of the patients we are caring for with COVID in the community have other underlying lung conditions, such as carcinoma of the lung or COPD. They may present with other pathologies, such as pneumonia or a new effusion. So it is important to consider whether there is another reversible problem. And thinking about non-pharmacological management of breathlessness. It can be helpful to assist the person into a more comfortable position. If they are able to sit out, leaning forward can help, perhaps resting forward onto a few stacked pillows if they are able. Advise them to let their shoulders droop, keeping the head up and the legs uncrossed. A simple exercise to illustrate the benefit of shoulder position is as follows. Advise the person to pull up their shoulders tightly towards their ears and to inhale and exhale. Then to relax their shoulders and drop them down, and then to repeat the exercise to inhale and exhale. They should find that it's much easier to take a deep breath in and out with the shoulders relaxed and down. Sometimes, in less severe breathlessness, relaxation techniques can be helpful. Some simple breathing exercise can be worth trying. Examples of this are as follows. Blow as you go. For example, breathing in before standing up and then blowing out as you make the effort to stand. Paced breathing. Breathing in for one step, then out for 2 steps. Some people find it helpful to visualise a shape which they draw when they're breathing in and out. So breathing in along the short sides, then out along the long sides. The emphasis here should be taking longer on the exhalation than the inhalation. Reducing room temperature can be very useful, where possible ensuring an open window with a flow of air. The sensation of airflow on the face can be hugely helpful in relieving a sensation of breathlessness, sometimes just as helpful as using oxygen. Cool the face by using a cool flannel or cloth. The sternal area is also helpful to apply a cool cloth in a similar way. Oxygen can be helpful if oxygen saturation is known to be low and if it is available. Then, thinking about pharmacological measures to help with breathlessness. There is good evidence that opioids can reduce the perception of breathlessness. Oromorph solution 2.5 to 5 milligrams orally as required may be a reasonable starting dose. Morphine 1 to 2 milligrams subcut if they are unable to swallow. Or morphine modified release can be commenced as an alternative. A suitable starting dose might be 5 milligrams twice a day, titrated up as needed. Note, if the patient is already taking an opioid, then the dosing will vary depending on their existing dose and which opioid this is. So if they are already taking oxycodone, it would be reasonable to continue using oxycodone for breathlessness management. Usually a lower dose of opioid is helpful for breathlessness than is needed for pain management. Anxiolytics can be used for anxiety associated with breathlessness. For example, lorazepam, 0.5 to 1 milligram sublingually as required, up to 4 times daily. When treating patients in the last days of life, morphine subcutaneously can be used, 2.5 to 5 milligrams if they're not already taking an opioid. And then for anxiety or distress, midazolam, 2.5 to 5 milligrams subcutaneously. Levomepromazine, 12.5 to 25 milligrams orally, can be used as an alternative if subcut meds are not available or unable to be given, and if lorazepam alone is not effective. Consider commencement of a syringe driver with morphine and midazolam over 24 hours if symptoms are persistent and the patient is approaching the end of their life. Then thinking about cough and non-pharmacological measures. It's important to advise on basic hygiene and infection control measures. So covering the mouth and nose with a tissue or sleeve when sneezing, coughing, blowing or wiping the nose. Washing hands after disposing of a tissue. Encouraging oral fluids as able. Trying things like honey and lemon in warm water or cough sweets. Advising elevating the head when sleeping and avoiding smoking. Then consideration of some pharmacological measures. Using simple Linctus, 5 to 10 milligrams orally, QDS, can be soothing and effective. Or codeine Linctus, again, orally QDS. If this is not effective and patients are more troubled by their symptoms, morphine sulfate immediate release can be used, 2.5 milligrams 4 hourly. If the symptoms are more severe and the patient is distressed, or if they are approaching the end of their life, morphine sulfate subcutaneously can be used in a syringe driver over 24 hours or as required. If all these measures fail, seek specialist advice. Then management of fever, defined as a temperature over 37.8 degrees. Associated symptoms and signs might be shivering, shaking, chills, aching muscles and joints. Simple non-pharmacological measures might be reducing room temperature, advising the wearing of loose clothing, cooling the face by using cool flannel or cloth, encouraging oral fluids as able, or consideration of pharmacological methods, using paracetamol 1 gram orally or rectally if the oral route is not possible. If a patient is close to the end of life, it may be appropriate to consider the use of non-steroidals. For example, diclofenac can be used 100 milligrams rectally on a daily basis. Delirium. Delirium is an acute confusional state that can occur when somebody is ill. It is a sudden change over a few hours or days and tends to vary at different times of day. People may be confused at times and then seem their normal selves at other times. People who become delirious may start behaving in ways that are unusual for them. They may become more agitated than normal or feel more sleepy and withdrawn. People with dementia are more prone to becoming delirious. So thinking about some non-pharmacological measures which are important to think about when a patient is experiencing delirium. Identify and manage the possible underlying cause or combination of causes if at all possible. For example, A patient in urinary retention or with a full bladder may present as delirious or more confused, or if they're constipated or experiencing pain and are unable to express this. Ensure effective communication and reorientation, and provide reassurance for people. Consider involving their family, friends and carers to help with this. Ensure that people at risk of delirium are cared for by a team of healthcare professionals who are familiar to the person at risk, if at all possible. And avoid moving people into a different room unless absolutely necessary, ensuring adequate lighting where possible. Pharmacological measures for delirium. Haloperidol is often the first-line choice for managing delirium when medication is needed to relieve acute confusion and distress. A starting dose would be 500 micrograms orally or subcutaneously at bedtime and up to 2-hourly PRN. If necessary, this can be increased in 0.5 to 1 milligram increments. A median effective dose might be 2.5 milligrams over 24 hours, with a range. Considering a higher starting dose, for example 1.5 to 3, when a patient's distress is severe, or if they are in immediate danger to their self or to other people. An alternative to haloperidol is levomepromazine, 12.5 to 25 milligrams orally or subcutaneously 4-hourly. If the patient remains agitated, it may be necessary to add benzodiazepine. For example, lorazepam 500 micrograms to 1 milligram orally or sublingually twice daily or as required. Then thinking about delirium or terminal agitation, managing these symptoms towards the end of life. Often a combination of levomepromazine and midazolam may be needed to treat confusion and agitation in the last hours to days of life. Levomepromazine can be helpful for delirium or confused agitation, starting at a dose of 12.5 to 25 milligrams subcutaneously stat and 4-hourly. If necessary, the dose can be titrated according to response. The dose range can vary between 25 to 200 milligrams over 24 hours. However, we would advise, if needing more than 100 milligrams over 24 hours, it would be advisable to seek specialist advice. Alternatively, smaller doses can be given as subcut boluses at night or PRN. Midazolam can be helpful for anxiety or agitation. Starting doses would typically be 2.5 to 5 milligrams subcutaneously and up to 2 to 4 hourly. If necessary, this can be increased in dose to 10 milligrams if agitation is a particular problem. Dose ranges can be from 10 to 60 milligrams or even up to 80 milligrams over 24 hours. If the above is ineffective, please seek specialist palliative care advice. In conclusion, it is important to emphasise that medication advice may be influenced by availability of drugs and may need to be individualised. If a patient's symptoms are not responding to the measures advised, please contact further specialist advice. Further advice around management of patients at the end of life can be found in the presentation Care of the Dying Person. If you have questions or concerns, please do not hesitate to call our 24-hour advice line on 01823 333 822 or 01935 709 480. For further information, see Caring for the Dying Person presentation, Treatment Escalation Planning Conversations presentation, available on St Margaret's Hospice and Somerset GP Education Trust websites. Thank you.